thought I'd start with a few things about some of the pharmacokinetic, pharmacologic characteristics of the integrase inhibitors. It's the newest class, and just to provide everybody an understanding of these drugs. And by the way, all of my slides are going to be available to you online, so if you've missed something, don't worry about it. You'll be able to download them without a problem. So in general, these drugs are really fairly similar. Bictegravir, dolutegravir, elvitegravir, raltegravir. I'm showing you the plasma concentrations, the peaks, the troughs. Sure, some differences in half-life, 9 hours for raltegravir, out to 17 hours for bictegravir. But when it comes to clinical dosing regimens, with the exception of raltegravir, they're all once daily drugs. All tend to be fairly highly protein bound. The excretion, all via the liver, some differences in pathways. Bictegravir, it came up earlier, actually from Jonathan. It does have a bit more CYP3A in terms of that pathway for clearance. And then the effect of food. They're all, absorption of all these drugs is enhanced when you give them with food, with raltegravir being the most enhanced, but it's also the most variable. And you've all seen previous discussions about pharmacokinetics and how variable raltegravir concentrations are from patient to patient. But just a quick summary of the PK characteristics of these drugs. Well, what about pharmacodynamics? So I'm showing you here the 4 integrase inhibitors and then the protein binding corrected 95% inhibitory quotient. So inhibitory quotients, or IQ, as it's often abbreviated, while they are not used clinically, they do provide you, I believe, at least our Food and Drug Administration in the United States believes, a useful frame of reference. I think the easiest way to think of an IQ, it's how much you need, how much you've got versus how much you need. So it's that ratio. What's the susceptibility of the virus and how much drug do you have there? And that's what IQ really tells you. So it's a useful way to compare drugs. And you can see here some differences, but they're largely very similar. The lowest is 8 for raltegravir. The highest looks to be bictegravir, up to 16. How does that compare if you add in protease inhibitors? Atazanavir at a 13. Darunavir, ritonavir actually has the highest of any that we've seen, up to 85%. While IQ is useful, I think there's some things that it's not quite capturing yet. And here would be a plea from a pharmacologist. I think we need to spend more time with virologists so that we can figure out how would be a better way to look at IQ. I will tell you, I think IQ probably does a pretty good job of telling you about inducing an antiviral effect. I don't know that it tells you maybe as much about maintaining it, about what happens if you have the emergence of one mutation or more mutations. I think something to work on there in the future. You all have, we've already heard discussions about the guidelines. I think we all know, at least from the American DHHS guidelines, that integrase inhibitors are now recommended as first-line therapies in the antiretroviral naive person. If you haven't seen this paper published mid this year from Annals of Internal Medicine, it looked at viral suppression trends then from 97 out through 2015. And rates down from 32% in 97 up now to nearing 90% in 2015. And that improvement in viral suppression strongly related to the change to integrase inhibitor use. So these drugs have made a real impact in patient care and improving virologic responses. Okay. To now move in a bit into delivery devices, let me start with the argument that the fixed dose tablets that we currently have for these drugs are pretty darn good, clever delivery devices in themselves. Here I'm showing you the 3 fixed dose tablets from Triumex, Abacavir, 3-TC, dolutegravir at the bottom to the newest Bictegravir, Imtracitidine, and Taft at the top. You can see the difference in the tablet sizes. So the ability to administer 721 milligrams, so that's total weight of that tablet. It's not the weight of each drug component. In a tablet that small, that's really a phenomenal accomplishment in drug delivery technology. So one might ask, why do we need anything more than these extremely convenient small tablets that can deliver 3 drugs? Well, I think it's going to come down to choice, convenience, compliance. I know I should say adherence, but it fits my 3 C's if I call it compliance. So here's some of the technology that's coming for drug delivery devices. Long-acting depot injections, microneedle drug patches. There are novel oral formulations coming, infusion pumps, vaginal rings, subdermal implants. And I think, as I mentioned, how these are going to fit in to therapy is largely going to be driven by patient choice, by the convenience that they offer those individuals, and then by compliance with them. So let me break away from HIV for a minute and use one of the long-acting antipsychotics known as aripiprazole. The oral formulation has been around, oral tablet of that drug has been around for a long time. And just a few months ago, a new injectable version of this drug was made available in the United States. And this is from the product literature website. Put patients on track treatment from day 1. And I think this may give a glimpse of what some of the options might be for long-acting injectables in HIV. So there's three dosage forms available. One is an oral tablet. It gives you a maximum concentration in 3 to 5 hours after you take it. It has a half-life of about 75 hours. There is now an intramuscular suspension that is nanoparticle sized. It gives you a maximum concentration, on average about a month, 27 or so days, and lasts between 15 to 18 days. And then there is an IM suspension that's a microparticle size, so a little bit bigger, has not a whole lot different in terms of its time to maximum concentrations, but an even longer half-life, out to almost 2 months, so 60 days. Well, here's a strategy that's been developed for using this drug. You use the oral tablets to make sure the patient tolerates the drug, so that's going to be fine. And then you can, in 1 day, give an oral tablet dose. You give the shorter acting intramuscular injection, and then you give the longer acting one either on that same day or between 7 to 10 days later. And this plot and these bars then show you, by doing that, within 4 days, you have now ramped up your concentrations in the plasma to maintain those out at what you would see if you had done 12 weeks of therapy. So if you know this patient is going to tolerate the drug, by using 2 different formulations of an intramuscular injection, you can just rapidly induce a response. And now you're out to every 2 months to every 3 months injection of the longer acting formulation. So I think it's a pretty clever strategy using these different dosage forms. What happens if you miss a dose? And this comes up a lot with the injectable HIV drugs. Well, they've thought about this, and right in the product literature made available to physicians, here's their recommendations. If you're using the largest dose, the 10,064 version every 2 months, if you miss the last injection, if it's been less than 10 weeks, you don't have to do anything. If it's between 10 to 12 weeks, you can use the shorter acting injectable to get concentrations quickly back up to where you need them to be. And then it goes on from there based upon the dose of the injectables that you're using. So it suggests that there are ways that if we want to use long-acting injectables for treatment, that we may be able to develop dosing strategies to accommodate missed doses if we need to. So let me come back now to the HIV drugs. What are some of the characteristics of drugs that are going to be suitable? Most of these are going to be developed from an existing oral formulation. That dose needs to be pretty low. You've got to have at least a medium-ish. Medium is generally considered 8-9 hours of a half-life or longer. Therapeutic concentrations need to be pretty low. The point here is you've got to load a lot of drug into these devices. So they need to be, pretty potent, pretty low doses to be able to do that. I'm going to talk now for the rest of my time about 4 classes of some delivery options that are either here or coming for the antiretroviral drugs. Long-acting injectables that we've heard about, implantable devices trying to meet Laura's demands, novel long-acting oral products, and then vaginal rings. So you've already seen, I think this is probably the 4th time now today, you've seen this slide. I'm not going to say anything more other than, this is the CAB, real pivoting data, and it shows you that these long-acting injectables work. You can, again, this one has already been seen, and that patients that are in these studies, and clearly they're declaring themselves interested in receiving an injection, have a high rate of preference and satisfaction with this delivery option. There's another type of long-acting injectables that are being developed, and these are nanosuspensions for tissue-targeted therapy. So what's important to understand in drug delivery technology is we can develop, from an oral formulation, a long-acting version of that formulation, and it won't necessarily change where the drug goes to. So if the oral doesn't get into the CSF, the cerebral spinal fluid, the long-acting is not going to either get into the cerebral spinal fluid. Or we can develop usually nano formulations that are tissue targeted. So now they become more engineered with the particle size, with the lipophilicity, with a whole variety of other physical chemical properties to try to go specifically to some body site. And that work is also going on with injectable anti-retroviral. So these are some work out of the University of Washington and Seattle in the United States, where they've taken tenofovir, lamivudine, lopinavir, ritonavir, combined them all into one nano suspension, and these are work giving that subcutaneously in the non-human primates. And what I really want to call out is this group is particularly interested in drug delivery into the lymphoid tissues, and showing you here that they indeed can achieve much, much higher ratios of the concentrations of these drugs in lymph node mononuclear cells than giving the parent formulation. So today, of course, we're hearing much more about just the long-acting formulations, much longer half-lives. But there's another, I think, emerging body of work looking at nano formulations to achieve targeted therapy. Okay, let me go to implantable devices. There is really a fair amount of work going on with this, and it's been there for some time. Here's an example of a long-acting Taft subdermal implant. It's really about the size of a hormonal contraceptive, a subdermal implant. It's been looked at just in animal studies so far, at least to the best of my knowledge, someone correct me if you know whether it's gone into humans or not, I don't think it has. And it can then achieve long-term delivery of drug. When they look at the concentrations of the intracellular triphosphate, so the active moiety of these nucleosides, they can produce levels that are above those that you see, for example, with tenofovir disoproxyl fumarate, so the TDF. So you can deliver therapeutically active concentrations of drugs through this implant for at least what looks to be a couple of months, if not longer. TDF and TAF are not the only drugs that have attractive characteristics for implant formulation. EFDA, this is the investigational drug that Merck is developing. It has been also looked at in implant formulations. And this drug may have characteristics such that you could be looking at 6 months of delivery of drug from a solid formulation. Again, all animal work. And maintaining not only the target plasma concentrations, but also the intracellular triphosphate concentrations. So one of the, I think, exciting areas of drug development work that's going on in pharmaceutical companies is trying to now design drugs not just for their intended therapeutic use, but more and more thinking about what are some of these unmet needs for drug delivery options, and can we design drugs to meet some of those needs at the same time we're trying to find out whether they work therapeutically or not. EFDA is a bit of an example of that. Novel and long-acting oral products. Again, Laura talked about the need for those, and I absolutely agree with her. And I'll show this slide from, again, this is the DHHS guidelines in the United States for treatment of HIV-infected children. And what is shown here are from infants to adolescents, the regimens that are recommended, and then whether there is a fixed dose combination available or not. And what you can see highlighted in yellow as you go from infants to children is no, 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 no. There just are not the same type of therapeutic options with these fixed dose formulations available for children as there are for adults. And I think this is just, it's a horrible unmet need to do that. Well, I think there's some work that's going on that's opening some doors for some development. So lopinavir, ritonavir, if you treat children, there is a commercially available solution. It contains both ethanol and propylene glycol. It's not what is really, you'd want to be giving to children, particularly premature babies, because of the risks of adverse effects. So this is from a group here out of the UK in Liverpool that has looked at now using this nanoparticle formulation technology to completely eliminate the ethylene or the ethanol and the propylene glycol. These are work in animals, but showing that they can maintain the same type of plasma concentrations with this. Now it's an oral nanoparticle. So sometimes they're injectable, but there is technology to be able to give some of these nanoparticles orally, and that's what they've done here. So if you can eliminate some of these solvents that you've had to use in children's oral products, it opens then the doors for, one, better oral formulations, but also being able to combine more drugs together if you don't have some of these solvents. Same type of thing going on with an efavirenz solid nanoparticle. Here it's a strategy to enhance the bioavailability, make these drugs better absorbed. Then you can lower the amount of drug that you actually have to give because you get the same type of plasma concentrations. In this case, showing that an oral nanoparticle has the ability to make a 50% dose reduction in the amount of efavirenz that you would have to give. So there really is some exciting oral formulation work going on. Well, this device shown here in the upper left-hand corner, I think for at least 2018, would win my prize for one of the most clever oral delivery devices, at least for this year. So it's in this case, it's a 6-chamber star. You see it up there. And it's a triangle type of formulation. And you can almost immediately begin to think about what some of the exciting advantages of a dosage form like that would be. You could put 2 drugs, the same drug in, and design those chambers to release at different times. Get an immediate release and get a sustained release. And clearly you can also put more than one drug in those different chambers. So we can now think about moving from just long-acting delivery of one drug orally to long-acting delivery of multiple drugs orally. And that's exactly what this group has done. So designing it then to be sustained release and to sit in the stomach, so engineered of a size then that'll reside in the stomach until it releases everything that it's supposed to release. Now the swine model happens to be one of the best animal models if you're just interested in oral drug release. And so in that circle in the radiograph, it shows now this device sitting in the stomach of a pig. And here an example where they've looked at dolutegravir and having it engineered to have an immediate release, so to rapidly achieve therapeutic concentrations, and then a sustained release of drug over time. So I think over the next couple years, you're just going to see a barrage of some of these very innovative types of devices to try to, I think, meet some of the needs that Laura, so nicely painted in terms of what we need to do to solve some of the challenging problems that are out there. Last, say a few words about vaginal rings. And I think some of the real exciting work in that field are the multi-purpose implants. So here's an example of just one. It includes an HIV drug for prevention. In this case, it's dapivirine, and then levonorgestrel for prevention of contraception. So a ring that does 2 different things. And again, I think this is another area where you're going to see some explosion of pretty clever devices for multiple purposes. Okay, so somewhat like Laura, to wrap up, long-acting injectables work. No question about it. The phase 3 studies are well advanced, and unless there's some catastrophe, it's hard to see how the current ones, the long-acting cabotegravir and rilpivirine, don't get approved and become available for clinical use. So it does become the now what question. I'm not going to go through every one of my points on this list, but it's things we've already talked about today. Who's going to be the best candidates, and what about children and adolescent and pregnant women? Can you eliminate the oral lead-ins? What do you do about missed doses? How do you stop therapy? How do you manage the PK tail? And we could go on for multiple slides if we wanted to. So they work. There's clearly still going to be some challenges to work out with them. What about the advantages and disadvantages of future strategies? Injectables versus implants. This is from a really nice paper that Charles Flexner published earlier this year, Current Opinions, HIV and AIDS, and so I'd refer you to that. But nice summary tables. What are the potential advantages, in this case, of implants over injectables? I agree with Laura. When I'm thinking of long-acting therapy, if something goes wrong, I sure would like to get that out of the body as soon as possible. Well, that's that I think is probably one of the biggest advantages that implants allows. It may be a minor surgical procedure to go in and remove it, but just as you can do that in a woman who's got a long-acting hormonal implant in, you can go in, remove that device, and now that drug is going to clear out by whatever the normal half-life of the drug is. And you just can't do that if you've got a long-acting injectable in the body. It's going to clear out via whatever the half-life of that long-acting injectable is. I think there's also some other advantages. The pharmacokinetics may be less dependent upon the injection, the injection site. You can design some of these devices to be biodegradable. That is, you're not going to have to go in and remove them when they're used up. You just put another one in. So I think there's some real advantages with the implant technology. Some disadvantages, sure, a surgical procedure to remove it if you have to do. Has been some examples of these devices migrating a little bit so they move from the site in which they've been implanted. The regulatory pathway can be a bit more challenging for these because, at least in the United States, they're going to be considered both a drug and a device. So a bit more of a complex process to work through. Generics, boy, it becomes a little hard to see how implants will really move into the generic marketplace really well because of that. You've got to have it engineered. It's going to be approved, again, as an engineered device and a drug. And that, I just can't think of it. Another example of where that's been done in the generic side. I don't think it's impossible, but it's something that would be very different. Okay, so I'll end then with some of what I think some needs are out there for novel antiretroviral drug delivery and some opportunities to improve patient care. I think the long-acting, there's both injectables. I think there will be implants. I think they have the potential to achieve 1 month, maybe out to 3 months, and potentially even longer. And so for patients who is a good choice for, I think those types of technologies are going to be available. Targeted delivery, whether that might be to areas such as the brain, such as to lymphoid tissues. If it's important, that's PK abbreviation down there, CT or CC equals CP. What that means is if it's important therapeutically that we get concentrations in a tissue or we get concentrations in a compartment such as the brain that are equivalent to what we get in plasma, these type of technologies of nanoformulations that are targeted may allow us to do that. New drugs, as I mentioned, I think one of the exciting things with new drugs is thinking about them not as just a new drug, but are there ways to deliver them to meet some of the unmet needs out there? So I think we're going to see some highly potent drugs that may be a bit more selective, some novel mechanisms, but they have some interesting possibilities in terms of how they can be delivered or how they could be combined with other drugs. And I'll put a real plea or plug, hope in for pediatric formulations and fixed dose combinations for children. So with that, I'm going to say thank you. It just was a tremendous delight to be here, and I'd be glad to try to tackle with Laura any questions that you might have. But thank you very much.